18, the chair lays out a committee substitute. The chair recognizes Chairman Van Dever to explain the bill.
Thank you, Vice Chair. Members, we hear a lot about the challenges associated with providing quality health care in rural Texas. Our office has provided you a map, and that map in front of you tells the story of what led me to file House Bill 18. Of the 13 members on the Public Health Committee, 9 of you are from urban areas with a total of 202 hospitals. But 4 of us represent rural areas which make up 28 counties and have only 30 hospitals throughout the entire area. 9 of our counties have no hospital at all. House Bill 18 is known as the Rural Health Stabilization and Innovation Act. It was filed to ensure that rural Texans have access to hospital and health care services and programs. Rural counties is defined as having a population of 68,750 or less. Under House Bill 18, there are 156 counties that are eligible. I'm going to go through a very relatively high-level overview of House Bill 18 and what it does. It's going to be a fairly lengthy layout. For that, I apologize up front, but this bill has a lot of moving parts, and so I do want to touch on those and the committee sub as well. House Bill 18 directs Health and Human Services Commission to appoint a new state office of rural hospital finance. This office will adopt a strategic plan so rural hospitals have access to the necessary services to treat patients, develop a financial needs assessment and vulnerability index to assess if rural hospitals will be able to maintain the types of patient services it currently does, meet their current financial obligations, and remain operational over the next 2 years. This office will also provide technical assistance to rural hospitals and healthcare systems. House Bill 18 also establishes the Texas Rural Hospital Officers Academy. The Academy will contract with up to 4 higher education institutions to provide professional development and continuing education programs for healthcare providers in rural counties. These academies will also offer at least 100 hours of coursework each year in courses and technical training that focus on the financial stability of rural hospitals and rural healthcare systems. House Bill 18 creates the following grant programs for rural hospitals. There are 4 grants established under House Bill 18. The Financial Stabilization Grant to support and improve the financial stability of hospitals at moderate or high risk of instability based on the Needs Assessment and Vulnerability Index. Emergency Hardship Grant for hospitals that have experienced man-made or natural disasters or unforeseen circumstances that might result in the facility's closure or inability to make payroll within 180 days. Third is the Innovation Grant to provide access to health care and improve the quality of health care provided to residents in a rural county that prioritizes improving facilities and services for pregnant women or women who have recently given birth, individuals under the age of 20, older adults, or individuals who are uninsured. And then finally, the Rural Hospital Support Grant to improve the financial stability, continued operations, and support the long-term viability of rural hospitals. House Bill 18 also adds the Health and Safety Code for the new Rural Pediatric Mental Health Care Access Program to use telehealth services to identify and assess pediatric patients seeking mental and behavioral health needs. This program is in addition to the Pediatric Teleconnectivity Resource Program for rural Texas that was previously adopted by the legislature and was modified in 2023. I want to be clear that to participate in the Rural Pediatric Mental Health Care Access Program, parents or guardians must give prior written consent for their minor child or guardian to receive these services. The committee substitute for House Bill 18 amends this section to include that a designated signer of consent for treatment for a minor child can include an adult with whom the child normally lives. Committee substitute for House Bill 18 also makes necessary conforming changes in the bill to reflect necessary changes when sections were moved from one section to another, and it also stipulates that effective dates of different provisions of the bill. Members, there are Texans who do not currently have access to hospitals and health care services that the majority of us take for granted. We have the opportunity this session to change that. I want to go over just a couple of highlights of the changes in the committee substitute. The committee substitute actually broadens the bill to include rural health clinics in certain counties to be eligible for funding where a county does not have a hospital but has a rural health clinic. It also restructures how the Texas Rural Hospital Officers Academy is structured so that the commission establishes the academy, and then the higher education institutions, which there are up to 4 of them, will implement the requirements of the academy. It also cleans up the structure of the 4 grant programs to clearly separate the specific requirements of those 4 grant programs from the information required of all the grant programs. It deletes the subject limitations on appropriations in Section 18 so that the commissioner can adopt a reimbursement methodology to pay rural hospitals that participate in Medicaid. It also requires the commission to calculate the prospective cost-based reimbursement rates once every 2 years. The committee substitute also includes a new funding arrangement between the Texas Higher Education Coordinating Board and Health and Human Services Commission beginning September 1st. This is for the money to flow for the academies that will flow through higher ed. And the committee substitute also modifies the requirement for consent services. I mentioned this earlier, that the parent, guardian, or an adult with whom the child primarily resides has to sign a written consent form for the services. And then finally, the committee sub modifies the reimbursement for services section to say that a child psychiatry access center may not submit an insurance claim or charge a rural hospital or healthcare practitioner providing services, a rural hospital that does not have a licensed general or specialty hospital located within its geographic area. They cannot charge a fee for consultation services or training opportunities. House Bill 18 is filed. Retained in the committee substitute says that a child psychiatry access center may submit a claim for reimbursement if the provider is enrolled and credentialed as a Medicaid provider. Members, that is an overview. I realize it's a relatively high-level overview of what House Bill 18 does. Again, this is an opportunity to shore up our rural hospitals and rural healthcare providers and meet the growing needs of rural Texas when it comes to health care. Madam Vice Chair, with that, I will stand ready for questions, and I know we have certainly some resource witnesses and others who wish to testify on this bill.
Thank you, Chairman. Are there any questions? Representative Frank?
Thank you, Chairman, for bringing the bill. Really appreciate it. I think I've got 14 counties, so definitely a lot of that is very, very rural. I think the addition of the clinics is a great addition. I don't know where that came from, but it probably came from your wise mind. But I think that's great because I think hospitals are changing. You're staying in there so much less, and really what people need out there is health care. So I think that is awesome. I was just going to mention one thing. I think and then I had a question about how the new organization was going to operate. But one on it says innovation grants. I just think some of the things that we're telling them they're going to train on page 4, it's ironic, and I think we do this to ourselves, but we start out with, and I think we have to, but it starts out with relevant state regulations, state and financial programs, right? It has nothing to do with actual running the hospital. And then it talks about maximizing revenue. I'd love to see us look in there something about efficient operations in healthcare. But it really is kind of a shame that part of the reason rural hospitals are struggling is because all the regulations get slammed down on them and they just can't keep up with it, and that's a problem we've created ourselves. So that's,
yeah.
If you want to, you look like you want to make a comment on that.
And that's fair. That is fair. And really, what we're trying to do here, and again, when we write bills, a lot of legalese and a lot of requirements, but what we're doing here really, because we have complicated the system like we have, what we're doing is really throwing a lifeline to these rural hospitals. We're providing services for someone to come out and say, here's how you can meet these needs. Come out and do efficiency studies. Yep. Here's how you can maximize efficiencies. And because many of these rural hospitals basically have one person who is the hospital administrator, and they may or may not be delivering trays at noon or whatever. That's just the way these rural hospitals operate. And many times they either don't have the training or they don't have the time to really manage the hospital
right.
in a way maybe a larger hospital has the opportunity to do.
Right. So what are we expecting of the new finance, I guess it's the rural hospital finance. Are we giving them power to go in and look at a lot of the issues within hospitals, or within rural hospitals in particular? Because I think that's something that, what I talk about, some of this we can talk about offline, but I think giving them the ability to look at some big issues, for instance, one of them is you'll have an insurance company pay, say Hospital X, $10,000 for a procedure, and then they'll pay the rural hospital $5,000 for the exact same procedure, which, to me, you go, well, it's a little hard to make it when you're getting paid half of what somebody else is 50 miles away. But I don't know if I don't think that's part of the purview, but I think it's something that maybe we can look at as we move down the road.
Yeah, I don't know that was the intent,
Yep.
but certainly something that I think we can look at. The primary purpose of the financial office is to really develop this vulnerability index.
Right.
To be able to judge these hospitals, to give us a warning when one is approaching the cliff, and to be able to develop these a matrix to determine when they're doing that. But part of that, I think, could very well be, hey, you guys are being paid half of what another hospital is being paid for these services, and so.
Well, I really appreciate it. I fully support the bill. I think we're doing a great job of protecting them from the problems that have been caused. I think if we can give them maybe at some point a little more authority to actually go fix some of the, waive the regulations
Right.
on these hospitals, or ensure that they are getting paid on par, those kind of things but I support it fully, so appreciate it very much.
Thank you.
Thank you, Representative. Any questions? Representative Alcott?
Thank you, Mr. Chairman. And Mr. Chairman.
Thank you.
Yeah, thank you for bringing this bill forward. And I know a lot of these small rural areas are really struggling, and there's people that are struggling to have access to medical care. One of the things that I frequently hear about is the potential cost of uncompensated medical care to people, foreign nationals in this country that are here illegally. And so one of my goals this session is to try to determine, how much is that, how much is the burden to taxpayers to fund health care for people that are in this country illegally. Would you be open to an amendment to actually have a reporting requirement, for these hospitals, these small rural hospitals, to how much it's, the taxpayer is spending on uncompensated care, along the lines of Governor Abbott's executive order back in the fall?
Well, let me say, I certainly appreciate your point, and think that's something, that certainly we need to be looking at. In response to your question, I believe the governor's order covers that, and what I fear is if we just add more reporting requirements, then we're really piling on to the problem we're trying to fix with these rural hospitals, where they don't have the manpower to do the reporting we're requiring of them now. And so my fear would be that as we, if we just add additional reporting requirements in this bill, then we're really just exacerbating the problem that we're trying to provide some relief to. But I'd be happy to visit with you about
Sure.
that.
Because, and I think I've mentioned this to the committee before, that I have personal experience down in Falfurrias. I believe that's Brooks County, where in around 2006, I was told, I spent about a week down there, that they're, up until recently, maybe it was a couple years before that, they had access, the children and the people in that community, and it's a lower economic, community that they had an emergency room, but because of the huge burden, it's one of the most heavily trafficked areas in Texas, and because of that, the emergency room had to shut down because they simply couldn't afford to provide free medical care to people that didn't have health insurance. And so, whereas I understand you're concerned about putting more administrative burdens on these hospitals, it's a serious problem, and I think hospitals have even shut down because of it, and I think that we need to get a handle on how much it is.
Yep. Thank you. I appreciate that, and I'll certainly look forward to working with you on that. And again, the hospital you mentioned, absolutely, they need some help. But, again, I'm not sure
Well,
we want.
they don't exist anymore. They had to close down.
Right. So, we want to prevent those situations from happening. But again, I think painting with a broad brush for all rural hospitals, the rural hospital in my district are not necessarily facing the same issues that hospital faced, or that maybe some others are facing. So, again, I think the governor's order pretty well covers that, and then I think we can, through this bill, I think we can give them the support they need, the hospital, the support they need to look at some of those situations that are causing these financial issues for the hospital, and give them the resources they need to address those, whatever that may be. But I appreciate that and look forward to working with you on that.
Okay, thank you.
Thank you, Representative. Representative Schaffner?
Thanks so much. Thank you so much. Yes, as 6 counties, when you said I had 6 hospitals in my county, I'm like, where? Literally had to go and count. So what are you including as hospitals? I know you added rural health clinic, but there's emergency room in one of my counties. There's an urgent care in another county. Some are private, some are public. So what are you considering county?
Yeah, I think what we were looking at when we got this information together, and by the way, when I looked at mine and saw I had 8, I had the same reaction. I can't name them.
Right.
And so, I believe that there are some, I know in one of my cities, we have what was a kind of an acute care facility that actually became a hospital because of some of the regulations we had put on them. And so they became a hospital, and we really don't see them as a hospital necessarily, but they are classified. So I'm assuming that maybe some of that is what's causing those numbers to look a little higher than you might imagine.
So what is a hospital? And what is just an emergency? Is it an emergency room, just emergency room, a hospital?
Well, I'll probably have to defer that
Yeah,
question to
sure. Okay, that makes sense.
HHSC because I don't know the textbook definition of what is a hospital, what is an emergency center, but I know there is a differentiation in the services they provide, and
So-
maybe they can provide some
So
clarification.
private, public, does that matter, or?
Not
it
for-
didn't
not
matter?
for this data,
Not for this
I don't
data.
believe.
So, or the program does not matter, can be private hospitals or public hospitals
We're
or county?
serving a rural county, a
The
hospital
end,
serving a
okay,
rural
great.
county.
And then with the finance, does it include that they would look at the pension programs possibly, if it was like a county hospital or a public hospital?
I'm sorry, I didn't.
The pension
Uh,
programs?
I think everything is fair game.
Okay, great.
I think they would go in and look at anything that has the potential to cost the hospital and any potential savings that the hospital could realize to help their financial situation, to make them more stable going forward.
Great. And with the academy, is that something that the county, it would be within the district, within the county?
That would actually be within a higher education institution. We would have from 2 to 4 higher education institutions across the state that would be willing to provide these academies. And it would actually be mostly off-site from the hospital. They would go to a location for these academies. Because, and we thought about, can we do some of it, by remote learning, and I think there is a possibility for that. We also recognize the importance of these hospital administrators from across the area, from across the state, coming together and forming a cohort.
Sure.
So then they have someone they can call as they face issues going forward. They can rely on each other to help them navigate these issues. So it will be off-site from the hospital, but again, we at no cost to the hospital, the administrator, they are not responsible for their own travel, any of the expenses to attend the academy. This bill provides for providing them their expenses so that they can travel to the academy and receive this training.
Okay, great. And then have those higher institutions, have they been chosen yet, or is there, how are they going to be chosen? Do you know?
Upon passage of this bill, the Higher Education Coordinating Board would, with coordination with some higher education, I said Higher Education Coordinating Board.
Yeah.
The Health and Human Services
I did.
Commission, in coordination with some of the higher education institutes, would develop the academy curriculum so that it's a statewide curriculum, so we don't have institutions across the state doing different things. And then the institutions of higher ed would apply to be one of the institutions that will deliver this instruction. And there will be a process. The commission will have a process to select the 4 higher education institutions to deliver and then we'll go from there. Once they're identified, then they will have the curriculum and they'll begin providing.
Great, thank you so much.
Thank you.
Thank you,
Thank you,
Representative. Any other questions? No more questions. Thank you.
We're good.
You have
Okay.
the right to.
With that, I believe, is there some people here to testify?
There are some individuals here to testify. Yeah, the chair calls John Henderson. So you are John Henderson, and you're with the Texas Organization of Rural and Community Hospitals, and you are for the bill, is that correct?
That's correct.
Thank you. You may proceed.
Thank you, Chair Van Dever. I couldn't have laid it out or teed it up any better than that. Thanks, committee members, for the opportunity to come and provide testimony. I'll be quick. My name's John Henderson. I'm the CEO at TORCH. That's an acronym for the Texas Organization of Rural and Community Hospitals. I've been in this role for about 7 years, and we are the primary voice for the 158 rural hospitals in Texas. All 158 are members of the association, and we're proud of that. I'm here to testify, as you said, in support of HB18. One thing we've learned, targeted rural rate enhancement and stabilization grant funding, and it usually doesn't take a lot, can pull rural hospitals and communities back from the brink of closure and the harm that follows, both in terms of access to care and economic development at the local level. Following 26 rural hospital closures between 2010 and 2020, we were ground zero for the rural hospital closure crisis. And thanks to state leadership and a real commitment to rural health care, Texas has only had one rural hospital closure in the last 4+ years. That was a hospital out in LaGrange in the fall of '23. Y'all deserve credit for that. Y'all deserve credit for that. HB18 builds on the grants that have really helped some of our most vulnerable rural hospitals and adds rural health clinics. A couple of our hospital CEOs will testify today, and it actually adds resources for rural obstetrics, pediatric behavioral health, financial training for rural hospital leaders, and funding for collaborative rural innovation. There are things our hospitals know they need to be doing, but they just can't do it alone. They need a little help. TORCH has had some success building groups and creating economy of scale through aggregation and bundling. We're happy to devote time and resources to further the aims of this bill if it's helpful. One additional call out and credit to Chair Van Dever for adding this in the committee substitute is the provision that fully captures the intent of SB 170 from the 86th legislative session back in 2019 to pay rural hospitals cost in Medicaid, not just subject to appropriations in the rider process, but reliably into the future. That's a big deal, and we're grateful. Once again, thanks for your ongoing support. I'm happy to answer any questions you have.
Thank you. Are there any questions? Representative Collier?
Thank you, Madam Chair. Hi, thanks for being here. I have a question about the closure. You said LaGrange closed the hospital. What happened?
They struggled, converted to a new designation called Rural Emergency Hospital in hopes of staying open. They had significant debt, as I understand it, on a facility that was built there and just could not handle that debt, so they closed after the conversion in October of 2023. I think there are efforts to reopen that, but it hasn't happened yet. So they just felt the strain of operational and financial pressure over a long period of time.
So it sounds like the rural hospitals, you know, they're required to have the same standards and equipment, and the facilities need to be the same as what someone would get in an urban area. But the return on the investment is just not there because of the limited number of people probably that visit their facilities.
Yes, ma'am. It's not all the same services, but the
Okay.
same standards
right.
for the services that are provided.
Right.
And problematic demographics. So just by nature of being rural, you serve an older, poorer, less insured population. So both of those things together put a lot of operational pressure on rural hospitals.
That's right. So maybe a tier 1 hospital where they see just everybody, or they have the different tiers. So that's what you were saying, is that depending on what the level of care that they're capable of accepting.
Yeah, so most of our rural hospitals don't deliver babies. There's some help for those that still are in this bill. A lot of them don't do surgery, don't necessarily have an ICU the way an urban hospital would. But for those services that they do provide, it's exactly the same standards as anyone else.
Now, would this bill help with transportation in terms of, like, if they need to have somebody care flighted or, you know, lifted out? Does this provide funding for that?
Not that I'm aware of. I don't think it speaks directly to that, but that might flow out of some of the assessments around, operational issues.
Is that something you think is important to have?
I have a little different view on that.
Oh.
This is my opinion, not Torch's. We always talk about how to get rural patients to the city for care. I'd like to see an effort made to get services to the people in the country.
No, absolutely, that's the top priority, but if you couldn't,
Yeah, of course,
Yeah,
of
okay.
course. When you have a cancer diagnosis, you need to go where treatment's available.
where do they go?
Most people for certain cancers go to MD Anderson in Houston, but there's oncology programs all over the state.
So the rural hospital, where are you from?
I'm originally from Childress, Texas, up in the Panhandle. So if you get a cancer diagnosis in Childress, you're more than 100 miles from treatment in Lubbock or Amarillo, Abilene, Wichita Falls. It's tough.
Now, would this bill provide grant funding for that type of treatment?
No, ma'am.
It does not, okay. All right. And so if the hospitals, you said there was 158 rural hospitals. And just like, how many people do you think are serviced by a rural hospital? I guess give yours, for example.
There are about 4 million rural Texans, roughly the population of Arkansas. The problem is they're spread over a lot of land. So to Representative Schaffner's point, I think this bill uses the Medicaid definition, which is a county population threshold of 68,000 to define rural, and that's how we get to 158.
Okay. All right, thank you.
Thank you, Representative. Representative Busey?
Thank you, Madam Chair. I want to jump on what Representative Collier was talking about a little bit. Can you talk to the bigger problem of rural hospitals and why we had 26 closed and in the last, since 2010? What is the leading cause of these closures, or what are some of the leading causes of the closures of rural hospitals?
Yeah, it's financial operational pressure, which this bill aims to improve. Now, that's 2010 to 2020, not
Yeah.
2020 to current.
So 26 hospitals primarily for financial reasons. This bill's going to help allocate through grant money an additional $10 million across the 158 hospitals. Is that correct?
I thought it was more than that, but I would have to check.
I guess in new money.
Yeah.
Can
158 counties.
158 counties. Can you speak more to the role of uncompensated care and the strain that's having in our rural hospitals? Are you able to talk to those numbers?
I don't know those numbers off the top of my head, but it's significant.
Significant? And you think that's one of the leading reasons why we're having rural hospitals closed? Because you said to your answer that we have an older and poorer population in these rural areas. So I would presume we have a high uncompensated care rate in these areas.
Yes, but that demographic is generally Medicare and Medicaid.
Yeah.
Yeah.
Okay. So uncompensated care, not enough dollars, were leading to closure. This bill will aim to help get resources together, help with these grants, help with getting the people the needs, and hopefully slow the growth. What else, in your opinion, do we need to be doing that this bill is not covering to make sure we're combating rural hospital closure?
I think this bill is a really good effort.
Silver bullet.
Not so. I'm not sure I would use that label, but very supportive of what this bill aims to do. Yes, sir.
All right. Well, in a little bit, Madam Chair, if we could hear from the agency, I'd like to talk more about rural hospital closure. Thank you.
Thank you, Representative. Any other questions? Representative Schaffner?
Thank you, Madam Chair. So what are other issues you just see in general besides financial for rural hospitals and the issues there?
I would put workforce at the top of the list, and that's not rural specific, but everyone struggles to recruit good doctors and nurses and technicians.
Okay, and so why are they just not moving to rural areas because the hospitals can't afford them, or?
That's probably part of it, competitive pay and bonus packages. The other thing is talented rural kids sometimes move to the city and get their training and then don't go back home.
Right. So what other options can we do to help alleviate that?
Well, separate from this bill, we're supportive of loan repayment programs for physicians and nurses that agree to live and work and serve in underserved areas of Texas.
And is that popular? Is that being used or utilized?
Yes, ma'am. It's a very good recruiting tool for rural providers.
Thank you.
Thank you, Representative Schofield.
Good morning. I'm trying to get to a very basic level. We have an urban wing over here. I'm from that rural bastion of Harris County. And before redistricting, I had 3 gigantic hospitals within 5 miles. I mean, any one of them would serve 3 or 4 counties out in the rural area. So, I mean, literally, when I turned to page 3 and saw State Office of Rural Hospital Finance, the first thing that goes into my brain is, oh, helping to finance them, because we have to build so many, we're gonna help with the process of getting financing. So we come from a different world when it comes to those sorts of resources than you do. So explain to me, if you can, how what we're setting up here, what it'll actually will do that will help keep us from having a repeat of the 2010 to 2020 closure era.
Yes, so I would start by saying we're the polar opposite of Harris County, where we come from, if you can't tell by my accent. And there's no contemplation of building new facilities in this, as far as I can tell.
being facetious.
It's more about how do we hold on to what we have.
That's what I'm saying.
Yeah.
What is it? I see we've set up the system. It seems to try to deal with kind of helping you maximize your Medicaid or Medicare. At the end of the day, if you have this tool that you don't have today, and you're sitting at your desk in one of these hospitals trying to keep it afloat, what is what we're doing here going to do that's going to help you accomplish that?
Well, different parts of the bill do different things. One part is actually that economic distress, and in some cases, I think the office would help people make it through a pay cycle just to stabilize. But in other cases, we're actually contemplating trying to do projects together, and I'm talking about like a shared electronic medical record infrastructure that they can't afford today on their own, and instead of trying to solve that problem locally, you work with a group of rural hospitals to have better systems that lead to better outcomes and efficiency across rural Texas. So things like that I actually get excited about.
And Chairman Bandiver was talking about sort of what I saw as sort of a canary in the coal mine system that would help identify early the hospitals are going to be in financial trouble. What does the bill actually do that would help you, again, if you're sitting at your desk trying to avoid this problem?
Yeah, there's mention of a vulnerability index in the bill, and it's basically an assessment not just of financial performance over time, but all these operating indicators that show you a relative strength or vulnerability, to say it the opposite way. And so you start by knowing who has problems or is headed for trouble, and some of the resources will be aimed at those folks that are looking over the edge of the cliff.
And so the idea, I guess, is to get to them before they get to the cliff.
Yes, sir. Yes.
Try to shore them up miles from the cliff.
Exactly.
Okay.
Keep them away from the edge.
Thank you.
Thank you. Any other questions? Thank you for your testimony. The chair calls, oh, I'm sorry, Representative Jones.
I've just got one question. You talked before about, I guess, economies of scale, so where one local hospital doesn't have the money or resources to put in the sufficient infrastructure. Are you talking about perhaps 4 or 5 hospitals, they can all pitch into the pot, perhaps develop, I don't know, some system to help them all be able to track the patients or what they need and those types of things? Is that what you're talking about?
That's one example, and for lack of a better term, like a co-op model.
Okay.
But it would be just purchasing too. You know, when you buy one CT scanner, it's a certain amount. If you buy 10 of them, you can get a better deal. My vision is that rural hospitals, by working collectively, can access better pricing.
And so with this, that made me have a second question.
Okay.
And so with this, is there going to be some kind of a committee that's made up of, I guess, executives from rural hospitals where they can talk about all these things? You don't know that?
I don't know.
Okay,
I'm sorry.
thank you.
Thank you, Representative. Any other questions? Thank you for your testimony. The chair calls Kia Presi.
Chairman Van Dever, Vice Chair Campos, and members of the committee, thank you.
Just a moment, sir. So we have you registered as Kia Parsi, is that correct?
That is correct.
And you are with Texas A&M Health Science Center Rural and Community Health Institution, and you are neutral on the bill, is that correct?
That is correct.
Thank you. You may proceed.
Well, Chairman Van Dever, Vice Chair Campos, and members of the committee, thank you all for the opportunity to provide testimony this morning, and thank you all for your support of rural health care in Texas. I am Dr. Kia Parsi, Executive Director of the Texas A&M Rural and Community Health Institute, or ARCHI for short, and I'm here to testify on House Bill 18. Prior to leading ARCHI, I was a rural Texas family physician for 20 years, followed by work as a hospital system chief medical officer and CEO. In my current role at ARCHI, our goal is to help rural hospitals and clinics succeed. From my experience, those that work in rural healthcare are highly dedicated, hardworking individuals. But as we've talked, the business of healthcare is complicated and highly regulated. Many rural hospitals and clinics do not have the bandwidth and at times expertise to fully optimize their institutions. Most do not have the budgets to invest in innovative initiatives or professional development opportunities. With the support from the 88th legislature, we were able to establish the Texas A&M Health Rural Engagement Program, or TexREP, where we provide technical assistance free of charge to rural clinics and hospitals. We work with Torch, with State Office of Rural Health, and other organizations to identify areas of need. Our regional technical advisors meet with rural hospital leadership to identify operational improvement. Let me give you an example. We asked about examples. A regional advisor met with one rural hospital, found out that they were starting a Medicare-supported chronic care management program. Great program, but they weren't billing Medicare for their services. They said their billing and coding vendor told them it's too complicated and not worth it. We told them you can bill and you should, and we will help you do it. So now they have a program that is not only good for their communities, but also sustainable. You will hear from two outstanding and committed rural hospital CEOs. ARCHI is currently working with both, using TexREP funds to provide expert consulting to evaluate their revenue cycle and other areas of operations to find opportunities for financial improvement. A Rural Hospital Financial Officers Academy is, as proposed in HB18, would be a formal way to offer training that is needed for our rural healthcare leaders and has the potential to move the needle. ARCHI stands ready to assist with such an academy. HB18 also describes innovation grants. As I mentioned above, many rural hospitals are barely making payroll. They do not have the financial capacity to start new programs and initiatives. Innovation grants can allow that to happen, and institutions like ARCHI can communicate this opportunity to rural hospitals and share best practices to help identify innovations specific to the needs of each community, utilizing their local resources and capabilities. Again, I want to thank the committee's efforts to strengthen rural health care. I am open to answer any questions.
Thank you. Any questions? Representative Sheltner?
Thank you so much. So what is this bill doing that you or others aren't already doing?
So as mentioned, the 88th legislature helped fund this. The academy would be a formal way. Now, we have our regional advisors. We meet with each hospital. This would be a formal way of doing what we've been doing, and also a way to make sure it reaches everybody that needs it. And again, what we're doing is specific for each hospital. What's your need? One hospital, they wanted to, they had a great ER, but they did not have stroke certification. So EMS would bypass their hospital on the way to Amarillo. We help them get that certification. So there are very specific needs for each hospital. The academy can be a wider brush.
Okay. And with the hospitals that you service, is it just Texas A&M Health Clinics, or is it every rural hospital that's on the Torch list?
Every rural hospital in Texas.
Okay, thank you so much.
Yes.
Thank you, Representative. Representative Frank? Okay. No, any other questions? Thank you for your testimony.
Thank you.
The chair calls Trace George. Good morning, sir. You're registered as Trace George, and you're with the North Reynolds Hospital District, and you are for the bill. Is that correct?
Yes, ma'am.
Thank you. You may proceed.
Committee chair and committee members, thank y'all for your time this morning. Had some written testimony prepared, but brevity is not one of my strengths, and I had prepared for 3 or 4 minutes, not 2, so I'll send you that written testimony, but I'll just get right to the point. I'm a CPA. I've been with North Reynolds Hospital District for since last June, so approximately 8 or 9 months. I've spent the last 30-plus years in healthcare, and when I arrived on the scene, North Reynolds Hospital District was in the coffin. The coffin was in the grave, and there were people over the hole throwing dirt in the coffin. So I want to speak to two things. The first one I want to speak to generally is the grants. The stabilization grants actually helped save this hospital. That's not just platitudes and talk. That's practical. I'm a walking, talking example of that, because when I arrived on the scene, like I said, they were in the death throes, and we're still here 9 months later. So in 2024, they helped keep the doors open, and I'll tell you, in 2025, it's going to give me some time to fix the operational financial issues that need to be addressed in that hospital to keep it going. So you're looking at a real boots-on-the-ground example of what we're talking about here. So that's number one, just the grants in general. But number two, as a CPA and a financial person, it gives me a lot of satisfaction to hear of an academy. What I told the board in the last board meeting is if I die in a car wreck on the way home, I'm going to tell you the worst mistake you can make is not have a financial person in this hospital. Small hospital districts and rural hospitals often can't afford a CEO and a CFO, so they get a CEO who is not a financial person. And hearing the words financial training is where I live and breathe. And you won't be able to spend better money than that, because any entity that has to cash flow is by definition a business. And if you don't have a financial person there, you better get training for the person that is there, because if you have a CEO who is not a CFO, they're going to need that training. So you could not spend money better than that right there. I'm sorry, I'm at 2:11, so I'll take any questions. I could go on for a couple of hours, but.
Thank you, sir. Any questions? Representative Frank?
I'm not going to let you go on for a couple hours, but I just wanted to have you add a little bit of color to this. There's expenses, there's revenue and expenses, right? Got to balance those. A grant will only address a little bit of it. Can you talk about how much changes? I mean, obviously, if you're going in the ground, it's probably because you've got either not enough revenue or too much expenses. Which side of the equation did you address, or both?
All.
Okay.
Obviously, revenue cycle optimization is what you're after, and A&M is helping us with that as we speak. But you need, there are so many layers of complexity within what we're talking about. And when you look at the revenue side of things and you talk about managing your revenue cycle from the second the patient calls to make an appointment or steps in your facility until you send the last bill to that patient after the insurance is paid, and everywhere in between, the charting, the coding, the billing. I mean, there's so many layers of complexity to that a person without that sort of knowledge, and even a person with that sort of knowledge, needs help from outside people. And the worst place you can be is to not know what you don't know. And that's where a lot of people find themselves. So that they don't even know what they don't know, and they don't know what help they need, and so they don't even go to get it. But if you have a good knowledge base and skill set to build on, and that training would help that. So I'm sorry I'm going off on a tangent, but so the revenue cycle management is the key piece for revenue, and I've taken better control of our revenue cycle doing that. But you also have to have somebody who understands how to look at expenses, and we can get into all these fancy metrics, and I can make your head spin with analysis on days cash, days in AR, so on and so forth. But at the most basic level, you're a person. If you need to budget what you spend, you're going to sit there and you're going to write down your expenses. And at even a basic level, some people just don't know how to do that.
Okay. Last question. What percentage of the people in your hospital, how many employees are there?
70 to 75, full-time and part-time.
How many of those are doing nothing clinical? Meaning they're just basically either doing regulations, billing, all of the stuff that is not clinical, is actually not taking care of the patient? Just ballpark.
Probably 20 people.
Okay, that's actually lower than I would have thought. I think it's lower. Okay, thank you.
Thank you,
Chairwoman.
Representative Schaffner?
Thank you so much. Your stabilization grants, where did you get those from? A&M, various?
Health and Human Services.
Okay. And I'm in Nacogdoches. We have the exact same issue. We're running about 10% right now, but we got a finance guy in charge of the board now who is doing an incredible deep dive, Philip Blackburn, incredible work right now. And so I thank you so much, because it's your passion that helps these rural communities and these rural hospitals to stay open. So I appreciate you and I appreciate your testimony.
Thank you.
Thank you, Representative. Any other questions? Thank you for your testimony. The chair calls Freddie Olivares.